Thank you. Good morning, everyone. Thank you so much for joining us on this Thursday morning. My name is Alice Tin. I'm a third-year family medicine resident at Swedish Cherry Hill Family Medicine Residency. And
I'm Emily Jones. I'm also a third-year resident at the Swedish Cherry Hill Clinic.
we have the distinct pleasure of talking to you this morning about health impacts of wildfire smoke, and we're really using this as a case study in climate change and environmental justice. This topic is very near and dear to our hearts. We both enjoy the outdoors immensely, and for myself, I have an interest in a topic called One Health, which looks at the intersection of environmental, human, and animal health. And what I really enjoy about this is that it really is an interdisciplinary pursuit where it brings many voices to the table, and we hope to demonstrate a little bit of that as we draw from different disciplines to bring you data to illustrate these health impacts.
And anyone who knows me knows that I'm an outdoor cat who likes to spend as much time as possible in nature. It's always been unclear to me why we separate environmental issues from human issues, although it's the literal water in which we swim. This was particularly evident to us this summer when we were just unable to ignore the increasing wildfires and the threat to both our lands and air quality. First, we're going to start by talking about climate change this morning and the myriad forms it takes depending on where you live. And then we'll talk a little bit more specifically about wildfires and focus on the data regarding the impacts on human health. We'll touch on how different communities are disproportionately impacted by wildfires and discuss the environmental justice movement before closing out with steps that each of us can take with our patients, both at the personal and systems level. First, a note on climate change. This is a term that's become really politicized over the past decade or so. Technically, this is defined as a long-term shift in global or regional climate patterns and often refers specifically to the rise in global temperatures from the mid-20th century to the mid-1900s to now. While there's broad scientific consensus across disciplines, and you'll see a lot of interdisciplinary scientific work today, the consensus is that this rise has been largely attributable to the increased consumption of fossil fuels. And there are still some people that believe that this is due to a natural cycle of warming and cooling that the Earth has experienced before. Regardless of what you or your patients or the broader community around you believe to be the underlying cause of climate change, we can all agree that the impacts are real, serious, and worth addressing. This is a diagram published by the New York Times that came out last summer, right when this happened when the American South was experiencing its worst hurricane season at the same time that we were experiencing our worst wildfire season. So this diagram shows, it's pretty self-explanatory, but it shows historically what to call climate change where you live and how it most impacts that geographic region. So for this vast swath in the center of the US, they're impacted by water stress. So we know like this part of the country is often experiencing drought. Historically, our part of the country has experienced extreme rainfall, which we saw a couple weeks ago with like several weeks of flood warnings and landslide warnings. And increasingly wildfires are becoming an issue here. So this is a simplified diagram, oversimplified, that really only shows the most prominent manifestation of climate change in our region, but now we're seeing that this is changing a little bit. For those of you who haven't lived in this area very long, it's really just been in the last 5 or 6 years that wildfires have started to become an issue in Seattle. And this diagram also serves as a reminder that climate change is not just temperature change and really is a reflection in extreme weather patterns of all sorts. This is another diagram that that helps emphasize that. If you look at this center circle, these are all of the different climate phenomena that are core to climate change. So we see rising sea levels, rising CO2 levels, and rising temperatures. And then we just talked about the more extreme weather. This first insight, or the second circle, are all of the environmental changes that happen as a result of these climate phenomena, including worse water quality, increasing allergens, and then change in vector ecology. Outside the circle, out here are all of the human impacts. So some of these are more closely medically related. We talk about asthma and air pollution, we talk about heat stroke, we talk about increasing, COVID in terms of changes in vector ecology. And so given the multitude of different weather changes, we experience a ton of impacts just based on little climate changes. We're going to focus specifically on air pollution, but just keep in mind that this is a small piece to a really complex puzzle. So going to the 2020 wildfires, this is when things really started to hit home for us. While the wildfire season has been getting longer and more pronounced over the past decade, last year was the first year that the entire West Coast was enveloped in this massive plume of smoke. And then perhaps we were a little bit more aware of this last year when a lot of us were trying to be outside as much as possible, following CDC recommendations for COVID to be outside. And then all of a sudden smoke came, and the recommendations for avoiding the smoke were in direct opposition to the CDC recommendations for COVID. So recall that Washington's fire season started in late July when a brush fire in Chelan County burned more than 3,000 acres. Several weeks later, a series of small fires were sparked in California as a result of a large lightning storm, a much larger than average lightning storm. And then shortly thereafter, months of dry weather and the Santa Ana winds contributed to the development of dozens of fires across eastern Washington, central Oregon, and throughout California. And then finally, the peak air quality index, which we'll get into it in a second, those readings were the highest for us between September 7th and 19th. So taking a step back to look at what's in wildfire smoke, the chemistry of wildfire smoke depends on what is burned. So are these trees, or are these homes, or are these businesses? It varies by wind condition, fire temperature, and location. Just briefly looking at a few of the big components, carbon monoxide is toxic, replacing oxygen on hemoglobin. Acrolein can cause flash pulmonary edema. Formaldehyde primarily causes neurologic symptoms, and benzene is highly carcinogenic. We're going to talk a lot about particulate matter, particularly PM2.5. Thanks for laughing, PM2.5, which got a lot of talk last year, and we'll talk about the distinction between PM2.5 and PM10. So this is clinically relevant. PM10 is anything with a diameter less than 10 micrometers or micrometers, and then PM2.5 is under 2.5 micrometers. The PM2.5 is often filtered by the nasopharynx and impacts the body a little bit less significantly because it's just filtered. PM2.5 can actually travel down through the air passages and get trapped in your lungs, where it causes inflammation and damage. If it's not filtered by the alveoli, it can cause long-term lung damage like emphysema, and then it can also travel in through the bloodstream, where it causes glutathione depletion. Taking a trip back to biochem, this is our glutathione diagram. Toxicological studies have shown that the major pathway through which PM2.5 causes both respiratory and cardiovascular damage is by indirectly increasing the oxidative stress and inflammation. Glutathione is one of the most prominent antioxidants in our body, and a study by Nakayama Wang et al. Showed that the human lung epithelial cells that were exposed to wildfire-derived particulate matter show glutathione depletion. So really quickly, Glutathione is one of our natural antioxidants, and exposure to wildfire smoke decreases the level of glutathione in our bodies. So a lot of us looked at this sort of diagram when we were talking to our patients over the summer. This is a screenshot from last week. That taken from January 13th. And at this time, we had a really great air quality index. And recall that air quality index takes into account mostly ozone, PM10, and PM2.5. This image also shows that the predominant contributor, which last Wednesday morning was ozone. Here are two different screenshots taken from that same day last week that shows overall the air quality index of the region was quite good, and then it breaks it down into the AQI for ozone and PM2.5. We're going to talk a lot about PM2.5. So the other thing that is a little bit annoying is that on the bottom here, you can see that there's a different AQI listed, and this is taken from a different station within the Seattle region, which just highlights the vast inter-station variability when we're measuring air pollutant exposure, even within just a few miles. So on the bottom, the really important thing to note on this slide is that AQI is not the same as the concentration of PM2.5, which we'll be talking a lot about. Here, with an AQI of 10, the concentration of PM2.5 was 5 micrograms per meter cubed. The EPA safe level for PM2.5 is below 35 micrograms per meter cubed. So keep these numbers in mind. We often hang out around 5, and the EPA safe level is 35. This data is from September 14th of last year, which is when we were seeing our peak AQI readings throughout the region. Although our PM2.5 regions right here in Seattle or the greater Seattle area were very unhealthy, around 207, they really paled in comparison to the hazardous levels that were seen in Spokane because they were closer to the actual fires. And then this is a little side project that one of the atmospheric scientists from UW had done during this time. So these it's a little bit hard to see on here, but on the bottom are the days. So this is September 9th through 16th. And then up here on the y-axis is the concentration of PM2.5. And just a real quick side note, this is in the Duwamish Valley, which is where our Seymour South Park Clinic is located. This river and the surrounding area is named in honor of the native residents of our land, and also has been declared a U.S. Superfund site, which is a special designation reserved for only the most polluted of waterways in our country. Side note. So here on this graph, we see that our baseline level of PM2.5 is around 5, and then sometimes, on a bad day, it peaks up at 20. But then during the progression of the wildfires, we saw these values go up to like 80, 90, 115. And as you all recall, this is what unhealthy air looks like. This is what Seattle looked like when our AQI was 197. So during this time, some researchers out of UW also modeled the increased cases per week of cardiovascular, respiratory, and all-cause mortality based on prior modeling. How they did this is they measured the PM2.5 levels in each county across the state before the wildfires and then during the wildfires, and then used that model to predict how many people would die and what the change in mortality rate would be. Overall, across the state, the average concentration of PM2.5 bumped over 90 micrograms per meter cubed, up from an average of about 4.3. So first of all, the two things to note here, they predicted that mortality numbers, deaths, would be highest in King County owing to our largest population in the state, but that the mortality rate would increase the most in Kittitas County, which is where Ellensburg is, due to their proportionally larger increase of PM2.5, where their values went up over 100 times their baseline. So they were around 500. And then interestingly, what we saw is that, the total of the respiratory causes and cardiovascular causes did not even come close to approaching all-cause mortality. So this is, for you visual learners, this is a visual representation of the same model where blue is our respiratory mortality, green is our cardiovascular mortality, and red is our all-cause mortality. What you can see, again, adding the blue and green together does not even come close to approximating our red line. So this raised two questions for us. What is driving the cardiovascular mortality, which here looks to be more significant than the respiratory mortality? And what makes up the remainder of all-cause mortality? So it is really hard to gather this data because these fires often last only for a couple of days, and the places that are most heavily impacted are often small rural communities from which a lot of people are forced to evacuate. So our population size is small in many of these cases, but there was a study from 2012 that estimated globally 339,000 people each year die from landscape fire smoke-related causes. This number includes landscape fires that are intentionally set for agricultural purposes, which if you look at this global heat map, here the red shows areas of fire, and then the yellow parts are areas of like increased fire frequency. So here on this map, yellow is the hottest or the most fire prone. And this data is actually taken from this same time period in September, except from 2015. And you can see that the areas most heavily impacted are South America, Sub-Saharan Africa, and also Southeast Asia, where a lot of these fires are intentionally set for agricultural purposes. And actually, that's also true for this area here, the American South. They do not experience wildfires like we do over here. And then just to drive home the point about the interplay between weather, climate, and mortality, the same study estimated annual mortality during La Nina years, which are these years with cooler seawater surface temperatures. And that was lower than the average, so 262,000 on an average La Nina year compared with 532,000 during the warmer El Nino years.
So next we'll take a deeper dive into the primary data around different health impacts of wildfire smoke. So first up, respiratory morbidity. So it's not a far logical leap to think that if we're inhaling these particulate matter, that it's going to first affect the respiratory airways. And so if you think about pre-existing sort of conditions such as asthma and COPD or chronic obstructive pulmonary disease, pneumonia or systemic inflammatory response, just kind of reflecting on the biochemical changes in our bodies that Emily talked about, these are sort of like what we would expect to see if there's air pollutants that we're breathing into our lungs. Just wanted to turn your attention to the graph on the right. So we're going to focus on the right half of this for now. We'll get into cardiovascular effects in just a bit. So on the x-axis there, you see smoke density stratified by light, medium, and dense. When we looked at this data, they didn't quite stratify what this was defined by, but then we have the relative risk here on the y-axis, and this is in comparison to smoke-free days. So you know, the general trend here is that if you look at the green, which is looking at all adults, it is a generally positive kind of dose responsive relationship between density of smoke and relative risk of ED visits for respiratory outcomes. And then they stratified these data by age, and just wanted to point out that for adults over the age of 65, they're disproportionately affected, and really the effect is about 1.07. So it's sort of like a 7 to 10% increase based on the density of smoke. So I want to turn our attention to kind of more, I think, like interesting data to look at the effects of wildfire on different pathogens, such as influenza. Just to kind of ground ourselves in influenza data, throughout 2015 to 2018, the CDC just does yearly surveillance on flu data, and the range goes from 21 to 49 million cases most years in the US, resulting in 140 to 960,000 hospitalizations, which result in about 79,000 deaths. And just to kind of quantify these direct medical costs, it costs our system about $10.4 billion. And I think it underscores why our public health systems really just put so much time and effort and money into flu prevention. Not to speak of, the morbidity and mortality that we as humans experience. This is a study that was done at the University of Montana in 2020, which examined both the they term short lag and long lag, or you can also think of it as short-term and long-term effects of PM2.5. And I think it's interesting for a couple points that I'll point out here. Just to talk through the four graphs that you see before you. If you look at the top half on the left, the top left corner here, you can see the years from 2010 to 2018. And then on the y-axis here, you have total weekly influenza cases. And so you can see kind of a clear spike here in the winter of 2012. But then, there are sort of like natural ebbs and flows. On the top left here, you have spatial data that's broken down by county, and so with darker blue colors representing higher flu incidence in those counties. And just a note that this data is specific to the 2015 to 2016 flu season. So it's just representing 1 year, whereas the graph on the left here is representing 8 years of data. On the bottom here, you can see same time period, 2010 to 2018, and then it's on the y-axis looking instead at weekly PM2.5 concentrations with peaks in early 2012, 2015, and 2017. And on the bottom left there, you also see this spatial data broken down by county, and it's also looking at the average for the 8 years of data that they have, aggregated and then color coded by density. And so you can see the northwestern part of the state has higher rates, sort of higher concentration of PM2.5 and pollution. And this also happens to be where most of the population resides. So the interesting things that came out of this study, because I think if you try to overlay the two maps on the right hand side, you wouldn't see like a very good correlation. But again, these maps are temporally showing different data. So I think that's something that's important to keep in mind. The thing that's interesting about these data, I think, is that most studies that have looked at wildfire impacts on like ED visits or medication use and things like that look at very, very short-term effects. So anywhere from 0 to 5 days. Whereas this looked at short-term, which they defined as 2-week effects, and then long-term, which is actually a year out. And so I think this really speaks to what we explored with the pathophysiology, because you wouldn't necessarily expect to see the effects of depletion of antioxidants in the body or the effects of oxidative stress necessarily within a 2-week window, and it's probably on the scale of months to years. The other thing is that I really love spatial modeling of data because these are basically data that are gathered from air monitoring stations in different counties. And so I think the things to consider here are that in urban areas, there are higher densities of air monitoring stations, and this is generally true of like most places. And then in rural places, there's going to be less density. But there's a mismatch, right? Because wildfires disproportionately happen in rural areas where there are less air monitoring stations. And so they do discuss that the spatial resolution for these data is about 12 kilometers or 7.5 miles. And so if you think about that radius, it's actually quite large, and probably, if there's not enough air monitoring stations to really pinpoint the the different changes within that region, it's hard to say like what one person, like where one person lives, like how they're affected by that concentration. And the other thing is that topography really matters. So Montana and Washington also, you can extrapolate this data. In the intermountain regions, there's an increase of poor air quality due to cold air inversions, which we actually saw, yesterday. There was kind of a haze that was over Seattle. And also there's trapping of air pollutants in mountain valleys, and this is also where most residents live. So I think these are all interesting points to consider. So getting to the data, when they looked at the 2-week lag or short-term effects of PM2.5 concentrations, they actually found no association, which I thought was a little bit interesting. And then when you look at the previous year's wildfire and PM2.5 concentration and its effect on like a year after's flu incidence, it actually did increase by 16 to 22% per each microgram of meter cubed elevation in average PM2.5 exposure. And again, we think that this is due to endothelial disruption in the previous year that causes immune suppression. This is borne out by animal models that have showed diminished capacity in pulmonary macrophages, which are some of our primary defense against viral particulates, to secrete IL-6 and IFN beta, which alters the immune response and decreases your resistance to flu. And this is really important, I think, for planning public health responses. So say we know that there was a wildfire event in the fall of 2020, we need to be preparing for flu season in 2021. Just to kind of further drive this home, just made this time course illustrating the wildfire season, which runs from July to September. And then the flu season really starts in October with a peak in January, which is highlighted for you here. And so I think things that were not included in the model that I think are important to consider would be flu vaccination rates, vaccine efficacy, which we know varies from year to year, socioeconomic status, school calendars, which affect the prevalence of viral diseases, and also healthcare access, because there's a differential there between urban and rural areas as well. And so again, harkening back to what Emily's point before, on top of this, in 2020 and now 2021, also, for wildfires, the overarching guidance was to close windows, close doors, to keep indoor air as clean as possible, or as high quality as possible, whereas that's in direct opposition to COVID guidance, where ventilation is encouraged. And then you also have to consider heat in the peak summer months, where wildfires also happen. And so just wanted to point out like how difficult these decisions can be in terms of making public health guidance and how to communicate that to the public. Now let's turn our attention, we began talking about this a little bit, but air pollution and coronavirus. And I want to broaden this to coronaviruses because we have some data from SARS, which there was a pandemic in 2003 to 2004. And so there was a study that was done in Beijing looking at the effect of PM10. And so I just want to call that out, that so far we've been talking about PM2.5, but now we're looking at PM10 data, where they really looked at a 6% increase in the relative risk of mortality for each 10 micrograms per meter cubed increase in the 5-day mean. So just keep that number in mind, because next we're going to look at projected differences and what this means for COVID-19. And so this top graph illustrates in the solid line here the actual mean concentration of PM2.5 in Seattle. And this is looking at Seattle data, actually. So this is from February 27th to April 16th. Here in the dotted line, they've superimposed the same time period, but data from 2018. And there was another air pollution event in that year. And so the authors of this study were taking this known quantity of 6% increase in morbidity and mortality. So in graph B here, you can see number of cases on the y-axis, and then in graph C, the number of deaths, so morbidity and mortality. They basically took the running average of PM 2.5 and then made a 95% confidence interval here, sort of assuming a 6% increase that was seen in SARS, and kind of projected like what COVID cases would look like. So I think this is a really interesting study. So sorry, just to make this more concrete. So for example, on March 26th, when the 2018 PM2.5 level was about 40 micrograms per meter cubed higher, one would project a 126% greater increase than actually observed. And so this was just really a model to try and help us prepare, because this data would be really interesting, even if it's not exact in terms of planning for hospitals and other public health considerations. So the important thing to consider here is that PM10 concentrations, they were assuming, were mostly contributing from like PM2.5, but PM10 and PM2.5 are not the same thing, as Emily discussed earlier. Another thing is that when we consider the data in Beijing, this is not a region that traditionally experiences wildfires, and so this is likely due to traffic emissions, and so the contents of the air pollutants are also different. So that's something to note. And then both SARS and SARS-CoV-2 or COVID-19 are both coronaviruses, and so you could maybe assume that the pathophys is similar enough that they would both be impacted in the same way by these pollutants. But again, I think it's important to call out that this is still an assumption. So switching gears to talk about cardiovascular health, due to the endothelial dysfunction that we've been talking about, we can expect sort of increased blood pressure and prothrombotic and coagulant changes, which result in higher rates of myocardial infarction, stroke, and CHF exacerbation or congestive heart failure. And so we're returning to the relative risk graph in terms of ED visits due to cardiovascular causes now. This is the same graph that we saw earlier. And again, just stratifying it by light, medium, and dense smoke, and then relative risk. And so again, we're seeing positive association. Also, again, that adults that are 65 and above are more disproportionately affected. So this is data that's come out of Australia, looking at cardiovascular health effects during wildfires, which are a recurrent problem there as well. So looking, if you look on the left there, out of hospital cardiac arrest data, and so they're looking at total out-of-hospital cardiac arrest, and I think this is because in the hospital there could be other acute illnesses that cause cardiac arrest, and so they're trying to really parse out causes due to organic cardiac issues, and so there's a positive about 7-point-something% increase in out-of-hospital cardiac arrests, and they stratified the data to show that a lot of this data is contributed by those who are above 65 and also male patients. On the right here, they're looking at ischemic heart disease, and we see much of the same trends, even though maybe a little bit of a smaller percent change. And they're also showing contribution from folks who are above the age of 65, and in this case, women were disproportionately affected in terms of ischemic heart disease. Looking at mortality, though, there was a study that was done in 2010 that really looked at or found for each 10 microgram per meter cubed increase in PM2.5 due to smoke, it contributes to the premature death of one susceptible person per day in a region of about 5 million people. And so to make this concrete, I thought that Washington State might be a good example, because our state population in 2005 was about 6.3 million, and so we can just kind of estimate those numbers. So if we take the 110 PM2.5 concentration that we saw earlier in Emily's graph about the, sort of like the peak or average concentration of the September wildfires. If we subtract 35, which micrograms per meter cube, which would be the EPA safe level of PM2.5 concentrations, we basically the calculation comes out to, for each day, 7 additional deaths at average or like peak PM2.5 levels. And if this is over a 2-week course, we would expect 98 additional deaths solely due to the wildfire smoke. And I think that this is not an insignificant number, especially when we're talking about a modifiable factor that tangibly contributes to cardiovascular morbidity or mortality. And I think we have a lot of other work and research to do in terms of how we can proactively be preventing this. Looking at one more group of things that is affected by wildfire, we're looking at the ways that wildfires pollutants can affect blood vessels in non-pregnant people. It also applies to people who are pregnant. And so we found data that shows that there's an increase in hypertensive disorders in pregnancy and also an increased odds with preeclampsia. And so called out that the odds ratio was increased to 1.51 with each 7.3 microgram per meter cubed increase in PM2.5. And this was particularly in the 3rd trimester. These trends kind of were borne out in preterm birth as well. And these authors stratified by exposure in each trimester and found that what was statistically significant was in the 2nd trimester with an odds ratio of 1.132. And interestingly, the effect on birth weight, it also was there was a decrease in birth weight with wildfire exposure in both the 2nd trimester and 3rd trimester. And so I think just wanted to call out a couple of things. One, that it seems like exposure to wildfire in sort of later trimesters has more effect on birth outcomes. But then the second thing to note is that when you look at these columns on the right, the decrease in birth weight, 9.7 grams, 7 grams, like this is not going to tip anyone in particular over from appropriate for gestation age into like as small for gestational age. Thank you. So we know that this is prime example of statistical significance, but probably not clinical significance. But I think the fact that it is measurable is still notable and probably points to the fact that there are other things that we're not currently looking at that are also affected. Lastly, I just wanted to take a quick look at systems and financial impact because I think this data probably drives a lot of our policy for better or for worse. There are lots of interesting ways that these numbers are generated, and I think that's beyond the scope of this talk today, but I just wanted to just briefly call out, for each case of mortality, we're estimating $7.6 million. For each workday loss, there on average is about 131, but there's definitely a ripple effect of those work days lost in terms of activity, childcare, many, many different effects. So I'm going to turn it over to Emily now.
So we know that these health impacts are compounded by other health disparities that disproportionately impact certain communities. This concept, formerly known as environmental inequality, is loosely defined as the environmental burdens that are borne primarily by Black, Indigenous, and other populations of color and other disadvantaged populations. Practically speaking, this refers to the interplay between many complex factors that are hard to account for, but also impact patient health, including the amount of airborne pollutants from nearby power plants, highways based on the physical location of a neighborhood, the amount of people time spent working outside, thinking specifically of agricultural workers or construction workers, modes of transportation, so people who are walking or biking and are exposed to higher levels of pollution versus those traveling in a private car or even a bus, and access to clean drinking water, thinking specifically about Flint and many other cities across the country, just to name a few. Larger media outlets, again, this is the New York Times, have been increasingly focusing on environmental inequality and its counterpart, its happier counterpart, the environmental justice movement. In late 2020, the New York Times published this story measuring the average exposure of pollution measured in fine particles per cubic meter, same form of measurement that we've been talking about over 24 hours of 2 kids living in Delhi and India. So what they do is, going throughout the course of the day, they look at, they measure the different levels of air pollution exposure on the bottom right in each panel throughout the course of the day. So they compare Manu's open air hut with Amya's windows and doors. Then Manu's bike commute with Amya's car commute. Monu's outdoor school with Amya's indoor school, and her access to an air filter both in her school and in her home. And then at the end of the day, they look at the individual air filters that they've been carrying throughout them. And these all are seemingly small, yet very significant ways in which their air pollution exposure differs. So at the end of the day, his exposure is more than 4 times what hers was. Of course, this does not just happen in India, this happens here. So this is a mechanistically similar study that was done here in the US in over 215 towns and cities that looked at the exposure to the smaller components of PM2.5. So here on the this furthest left panel is the total PM2.5, and then it breaks it out into all of its subcomponents or some of its subcomponents. And so this graph shows the percent difference in exposure between these different populations. So in a true reflection of the white supremacy of science, the null here, 0, is the white population. This black bar is the non-Hispanic African-American population. Blue bar is the non-Hispanic Asian population, and gray is the Hispanic population. So just speaking in broad strokes, it's pretty obvious to see that although the overall exposure to PM2.5 on the whole is not hugely different, if we look at these subcomponents in general, all of these populations are increased from baseline compared to a white population. And also in general, the Hispanic population has the highest exposure overall. They also looked at some other binary categorizations that are a little bit more difficult to graph here. So this white bar is, less than high school compared with college education. The black bar is unemployed compared with unemployed. So like here, the null is, black bar is unemployed, and the null is employed. Gray is below poverty, with the null being above poverty, and then blue is earning less than 15,000 compared to a null of greater than 50,000. So what we see here on this graph, which perhaps unsurprisingly, not completing high school, being unemployed, being under the poverty limit, and having less than $15,000, making less than $15,000 a year, are all risk factors for increased exposure. Granted, like there's a lot of overlap among these 4 categories, and then a lot of overlap with the systemic racism shown in the last slide as well. Of note, the authors do not comment on this obvious outlier, showing that folks making less than $15,000 a year are markedly less likely to be exposed to nickel. They did not comment on that. I suspect it has something to do with nickel being involved in oil combustion and being maybe further away from power plants or highways, but that is pure speculation. So we wanted to draw a little bit of attention to the people who are on the front lines of wildland firefighting. There are about 10,000 wildland firefighters across the country, mostly in the West Coast where most of our fires happen. Those who protect us are often young seasonal workers who spend months each year placing their bodies and lives at risk daily. Increasingly over the past decade, incarcerated populations are called upon to fill this gap. Right now, they constitute at least 10% of the firefighting force, though this past year it's been population has been impacted by early release, fortunately, due to COVID, unfortunately. but these workers make about $25 a day for their life-saving work. We all know that BIPOC communities, and in particular Black communities, are incarcerated at markedly higher rates than their white counterparts. And we just found this to be a striking embodiment of those whose lives are at risk as wildfires and climate change become increasingly problematic.
So now that we have all this data, what do we do about it? When we look at clinical care, I think knowing that there are so many health impacts of wildfire smoke, I think, and knowing the high risk populations such as the elderly population aged above 65, I think we can use that data really to do proactive clinic outreach, especially if we know that wildfire season is almost upon us. We can have like focused respiratory and cardiovascular clinic during these events as well, and do a lot of anticipatory guidance. And knowing that medications like inhalers are going to be really life-saving for those particularly with respiratory conditions, streamlining prescribing practices so that patients have early and frequent access to these medications is going to also be really important in terms of lowering the overall morbidity. Aside from this talk, if you were really interested in getting more information, the CDC and the EPA actually.
From this point on.
Hi, if you could put yourself on mute, that'd be great. Okay, I thank you. So for more information, there's actually, I've gone through the training myself, and actually the wildfire smoke, this online training is quite good. In terms of home interventions, one of the other tiny silver linings of COVID is that we're a lot more comfortable with using pulse oximeters to monitor home O2 stats. And I think this is really great also because it puts the power back in the hands of the patients as well, to really own their data and to kind of have actionable items on them as well. As was mentioned before, air purifiers are really going to be an important part of maintaining high indoor air quality during wildfire events as well. And they don't need to be expensive. The Colville Tribe's air quality program, we just wanted to give a special call out because they made an excellent DIY version. There's a link to their YouTube video. Just looking at the screenshot, you may have roaring flashbacks from college days with these white box fans. And then you can also buy these air purifiers, and they have a step-by-step guide on how to build these, which was awesome in a cost-effective way. Speaking of knowledge as empowerment, I think airnow.gov has really been helpful in our research for this talk, but also I think is a great tool for everyone. You can see that it has a nice clear color code in terms of the air quality based on AQI. And it will tell you again the predominant pollutant. And then here I've just showed a table that delineates like how they determine what AQI matches with what air quality, and gives guidance on like what activities are okay. So in the vein of anticipatory guidance, this comes from the Santa Barbara Air Control Pollution District, which is a nice infographic, which counsels people, particularly if they have heart or lung issues, to limit their time outdoors or to avoid outdoor excess, or at least decrease the intensity, and some guidance about indoor air quality as well. And I think it would be also a great opportunity to call in environmental scientists and meteorologists to have input on what goes into this infographic. And I think also calling on different communities in terms of like what pictures or images would be like appropriate to convey these concepts. So talking about sort of like more systemic things that can be done. This headline comes from a press release from the King County Department of Public Health, which recognized the confluence of COVID-19 and wildfire smoke, and they opened cleaner air shelters for people experiencing homelessness, which I think is also a really important step, not only for those who are experiencing unstable housing, but also those who don't have access to air purifiers or other potentially life-saving measures. This it comes again from the New York Times, but it, I think, shows a couple of things that are important in terms of using our platforms as clinicians and providers to advocate for really drawing attention to the importance of air pollution on health. So briefly, this documents the death of a 9-year-old female due to a fatal asthma attack. So her story is that this happened in the UK, and she lives near a major circular road where there was just documented like terrible air pollution due to traffic emissions. And before her death, in the preceding 3 years, she had over 30 ED visits that were due to asthma exacerbations that led to complications such as seizures and intubations. And this was notable because her doctors listed, when we list cause of death, air pollution as the main cause of death. And I think this lends a lot of weight and credence to the legitimacy of air pollution and drawing that direct link to her death. And I think that sets a very important precedence for how we think about cases in the future. So bringing things kind of closer to home, like what can we do? This is a call to action naming climate change as a public health emergency that was put forth in 2019, calling for action on larger governmental organizations such as Congress. And over 100 health agencies signed onto this, and I wanted to highlight some of the ones that may seem familiar, particularly the Seattle and King County Public Health Department and the Washington Physicians for Social Responsibility. This is just a snapshot of a resolution that was presented by Dr. Mark Vossler. He is a cardiologist and part of the Washington Physicians for Social Responsibility Board. And I think this calls attention, obviously, to climate change and health within the Medical Association in Washington State. But I think just based on our experience from the 2020 wildfires, it can also be important maybe for physicians to have a voice in terms of like wildfire management policy and, again, fostering that interdisciplinary collaboration. This is a snapshot of physicians testifying to the King County Council. These were all members of Washington's Physicians for Social Responsibility, and they were testifying specifically on a fossil fuel moratorium. And so pictured here is Dr. Diane Glover, who's a pediatric infectious disease specialist, talking about the adverse effects of wildfires on the lungs of her patients who are prematurely born babies. This is a snapshot from the Seattle Times. It's an op-ed article, which is yet another way that we can advocate if you're like more on the introverted side and writing is more your medium. And this is from September of 2020 and brings to light climate change and wildfire smoke, bringing those two together and also talking about the health impacts. And so we're calling out the authors here because one is a pulmonary and critical care physician, and the other is the director for a clean energy nonprofit. And so I think this also exemplifies the cross-industry collaborations that can be very powerful. So in conclusion, I think there's a lot of really convincing data that shows us the health impacts of wildfire smoke. And we really hope that this data can help you make decisions about how to counsel patients, and that there's some practical aspects in terms of what you can take away, not only in terms of patient care, but also advocacy, so we can keep the really beautiful spaces that we've been gifted with for generations to come.
And one more piece of good news that didn't make it into this presentation because it just happened yesterday evening was that President Biden signed an executive order last night that brought the US back into accordance with the Paris Climate Accord. So there is some national movement towards aligning those values.
Thank you so much for your time, and we would be more than happy to take questions now. The chat function, we apologize for the disruptions during the talk. I believe the chat function has been disabled, so at this time you can maybe request to be unmuted and then ask your questions that way. Megan and other folks from the Seattle Science Foundation, we'd love your input on that.
And separately, you can email us if you have further questions.
Yeah. We also wanted to thank Shannon Waterman and Dr. Barry Saver, Dr. Shannon Waterman and Dr. Barry Saver for their comments and assistance in developing these slides, and also to everyone at the Seattle Science Foundation for their assistance in making this talk possible.
Great job. I do apologize for those disrupting chats and the disturbing ones. We did get hacked, it looked like. If you do have any questions, feel free to email CME at Seattle Science Foundation, and I will forward them to Alice and Emily.
Okay, I'll go first.
Okay, I would like to ask a question. If there's a wildfire fallout, it would cross other states. So if California have wildfire, the health cost and the environmental cost impact will go to Oregon and Washington. And in fact, I know even internationally, I remember each year Indonesian farmer, they would burn their vegetation on purposes, and it would affect Singapore and Malaysia. So my question is, should that, in terms of the 50 states of America, shouldn't this initiative of awareness and education and prevention and treatment be interstate, meaning at a federal level, as opposed to at a Seattle Science Foundation level, maybe even greater than a Washington state level, that the sharing of science and prevention should be at a federal level, and maybe even at some point at an international level. In other words, if the butterfly effect is true, then the fire in Washington state will affect Norway, which is a beautiful country. So we should look at it even from a sustainability angle, that our conversations should be greater than Seattle Science Foundation and beyond Washington state and the 50 states, but a global climate change discussion. Thank you.
Thank you so much for that comment. I think it's absolutely true that smoke knows no state boundaries nor international boundaries, and so Canadian wildfires certainly affect the U.S. and vice versa. So I think this really underscores the importance for not only interstate collaboration, but international agreements. And so, like Emily was saying, the Paris Accord and these international agreements are also really important. And I think what wasn't within the scope of this talk was also just the sort of like migration of pollutants from sort of wealthier countries to poor countries, as we look at like the migration of like industrial work and other variables. So I think that's why the multidisciplinary collaboration is so important, because environmental effects affect us all, and it doesn't stay within our borders. So thank you so much for that comment.
Thank you for the answer. But just like the CO2, I think bearing other areas caused by a different jurisdiction is very unfair. Meaning we might be suffering healthcare when the cost of the fire or other pollutant are from other geographic area. And this is really a financial matter that is very important for the budget as well. So thank you very much.
Thank you so much.